Thank you for joining us for Talking Philadelphia Positive Acute Lymphoblastic Leukemia, Philadelphia Positive ALL, Improving Outcomes of Frontline Treatment and Mitigating Relapse. In this segment, we will be discussing the best tyrosine kinase inhibitor, or TKI, for frontline treatment of Philadelphia Positive ALL. I am Dr. Richard Stone, Chief of Staff and Director of Translational Research in the Adult Leukemia Program at the Dana-Farber Cancer Institute in Boston. I am joined by my colleagues, Dr. Katarzyna Jamieson. Katarzyna, do you want to introduce yourself?
Hi, I'm Katarzyna Jamieson, and I'm an associate professor at the University of North Carolina in Chapel Hill.
And my colleague and friend, Dr. Farhad Ravandi.
Thank you, Richard. I'm Farhad Ravandi. I'm professor of medicine in the Department of Leukemia at the University of Texas, MD Anderson Cancer Center.
Thank you so much, Farhad and Katarzyna. Well, we all know that acute lymphoblastic leukemia, when we started our training, those of us who are a bit older, viewed it as a very adverse disease with a poor prognosis and something that was quite feared, frankly. The prevalence is fairly common in older adults and less common in younger adults. The incidence ranges about 1% in pediatric ALL, all the way up to 25 to 33% in older adults with ALL. But what we're going to be talking about today, of course, is improvement in outcomes due to better therapies, specifically tyrosine kinase inhibitor therapies. Historically, compared to Philadelphia negative ALL, Philadelphia positive ALL was considered to be unstable with a high mutational burden and where resistance to available therapies were common. And that still may be true in certain respects. So we're going to begin by talking about someone walking in the door with Philadelphia positive ALL. And I'd like Dr. Ravandi to begin by telling us what he thinks the key elements that clinicians think about when they see a patient with Philadelphia positive ALL might be.
Thank you again, Dr. Stone. So the treatment of Philadelphia positive ALL, as you mentioned, has undergone a dramatic progress over the last 20 years. And, it used to be considered one of the worst prognosis subsets of acute lymphoblastic leukemia, but with the development of tyrosine kinase inhibitors that we will talk about, including imatinib and the more second and third generation ones, the treatment has significantly improved and outcomes have improved. So there have been historical risk factors for ALL in general, things like age and high white cell count. And to some degree, these have been negated by the development of these tyrosine kinase inhibitors. So the outcomes have generally improved. However, some of these risk factors, they still remain a problem. For example, with the older age, use of chemotherapy or cytotoxic chemotherapy is a lot more difficult, obviously. So most patients, when they arrive, obviously not in the tertiary centers, but in the referring hospitals, the presence of the Philadelphia abnormality is not known. So many patients are initially treated with steroids to just temporize the therapy. And of course, when the results of the Philadelphia abnormality become available, either by cytogenetics, FISH, or by molecular analysis, the treatment or the addition of tyrosine kinase inhibitors can be initiated. And I think that's what you were alluding to.
Yes, and I'd like to ask Dr. Jamieson if there are clinical features of a patient who presents with acute leukemia that might clue you into strongly suspecting that the patient might have Philadelphia positive disease.
Well, occasionally we see patients who we see, especially older patients, who will kind of present with the features that are kind of reminiscent of like CML transform into lymphoid blast phase. I mean, you will see a bit of a left shift, etc. Other than that, I just do not really think that we could often predict which patient is going to have Philadelphia chromosome versus not. We're actually fortunate that we, at our institution, we can receive the results of FISH for BCR-ABL within 24 hours. And these days, this seems to be really necessary to treat those patients appropriately.
I agree. Sometimes a patient might have evidence of a primordial leukemia. They may have some myeloid markers on top of mainly lymphoid markers that might clue you in this is a primordial disease. As we know that for years we've known that when CML goes bad, it can sometimes degenerate into what looks like Philadelphia positive ALL, which we would normally call CML in lymphoid blast crisis. That's about 25% of CML patients when they go into blast crisis. The other 75% have more of a myeloid disease. So we might want to look at the transcript size in general. P210 is seen in someone with Philadelphia positive ALL who's come from CML, where a P190 is a more typical Philadelphia positive ALL transcript size. But in any event, we have a patient with lymphoblasts that are Philadelphia positive, as Farhad said, by FISH, by cytogenetics, or by molecular, looking for the characteristic BCR-ABL transcript emanating from the fusion chromosome. So now we have a patient with CML and with the Philadelphia positive ALL, and we have to begin treatment. I think I just want to get some confirmation from both Farhad and Katarzyna that a tyrosine kinase inhibitor is absolutely required in the initial treatment of someone with Philadelphia positive ALL. Do you agree?
Yes, I totally agree. And even, I mean, I'm sure we're going to discuss less intensive and more intensive therapy, but I think the one constant is the use of tyrosine kinase inhibitors. And different people are going to have different opinions about which one, but I'm sure we're going to go into that.
So why don't we move right into that, Katarzyna? I'll assume that you agree with the need for a TKI, either with a lot of therapy or a little therapy, and we'll talk about that in a minute. But we have to choose a tyrosine kinase inhibitor. Of the 5 ATP binding site tyrosine kinase inhibitors we have. Of course, now we have a 6th that's an allosteric inhibitor, but not yet really used in upfront Philadelphia positive ALL, to my knowledge anyway. So Katarzyna, how do you think about which tyrosine kinase inhibitor to choose for our Philadelphia positive ALL patient?
So this is truly an interesting question, and again, pertains to which specific regimen, how intensive you wish to be, and actually which regimen you decide to use. At our institution, we actually routinely use dasatinib. For induction, I see many patients, a number of patients from the community, and it's not unusual actually to see patients treated with chemotherapy, anti-imatinib, etc. However, I think dasatinib is just used the most widely. Now, we're all aware of data with ponatinib, which is truly excellent. However, using it in the first-line setting could be challenging, depending on the institutional constraints, etc.
And why, Farhad, do we not? What are the advantages, disadvantages of ponatinib in the frontline setting?
So ponatinib is a very, very, very potent TKI against not only T315I, which is the mutation that is known to be a mechanism of resistance for many of the cases of Ph-positive ALL in relapse, and perhaps exists in at the time of diagnosis in some patients, although there's still some debate about that. But it does have its, like any good thing, it does have its package with it. There is great concern about cardiovascular toxicity, and original studies where the dose of 45 milligrams of ponatinib was used in CML particularly, and also in Ph-positive ALL at our institutions, we did encounter unusual cardiovascular events even in younger patients. So of course, people have become a little bit anxious about using ponatinib. However, there is now more recent data using lower doses and degrading the dose. So you initially start, if you want to start in Ph-positive ALL, particularly with 45 milligrams, we do that in the first cycle, and then in the subsequent cycle, once the patient is in complete hematological remission, we reduce it to 30, and then once in complete molecular remission, down to 15. And with that strategy, the cardiovascular risk, at least with the follow-up that we have had so far, has not been significant. Of course, if there is a patient who does have history of cardiovascular issues, with significant cardiovascular or coronary artery disease risk, you probably want to avoid that. But because it's the most potent TKI, and particularly against T315I, in my opinion, that's the TKI of choice in Ph-positive ALL.
Sure. I think some people think that either dasatinib or imatinib should be used because there are other ways to deal with the T315Is we'll come to using antibodies, which we'll mention based on some work done in Europe. So dasatinib certainly is, as you said, I agree, the most commonly used drug. And that's based in part on work done by Robin Foa from Italy, who's shown that dasatinib and minimal therapy, mainly steroids and physical therapy, leads to a high remission rate. And there's ways we'll talk about later that can actually make the remissions deeper, if you will. But T315I can emerge as a problem. In terms of imatinib, it's been around the longest, but I think most of us shy away from that because of the results that I just alluded to with dasatinib and either minimal or lots of chemo. Dr. Ravandi, you performed an important trial in which dasatinib was combined with chemotherapy, where the results were good. Do you want to tell us about that briefly?
Yes, thank you, Richard. This is the intergroup study that was led by SWOG, where patients younger than 60, initially it was actually younger than 50, but we extended it to 60, with Philadelphia positive ALL, were treated with the combination of the hyper-CVAD regimen plus dasatinib, and patients would be offered allogeneic stem cell transplant in first remission if this was available, or would just continue therapy with the chemotherapy plus dasatinib and followed by maintenance. The patients who also had transplant did receive post-transplant maintenance, and I think that's another topic that we will be discussing later. So essentially, this was a highly effective strategy, and as compared to previously published data using imatinib in terms of response rate and durability of response. In this study, solely in younger patients and generally younger and fitter patients, the use of allogeneic stem cell transplant in first remission was associated with an improved outcome, including improvement in overall survival. So this study, a phase 2 study, not a randomized study, did show a benefit for addition of dasatinib to the hyper-CVAD regimen, as well as allogeneic transplant in first remission and post-transplant maintenance, although this was not specifically looked at in the trial.
Excellent. Dr. Jamieson, what do you think the major goals of induction therapy in a patient with Philadelphia positive ALL should be? What endpoints should we shoot for?
So definitely I think we could approach it in a sort of stepwise fashion. It's in the past we used cytotoxic chemotherapy to induce those remissions. Then we added tyrosine kinase inhibitors. Then, as of 2005, as you mentioned, the European group kind of demonstrated that the remissions could be induced with just TKI and steroids without compromising long-term outcomes. And the question emerged: what quality of remission are we actually after? And the longer we play with those regimens, the more we realize the significance of achieving a complete molecular remissions. So basically, the deeper molecular remissions, the better the outcome. And we, in clinical trials, we're actually gathering more and more evidence to support that. Having said that, I guess it depends when you would like to assess the remission and what regimen you decide to choose. So in more intensive regimens and third generation TKI inhibitors like dasatinib and specifically ponatinib, we are able to achieve deep remissions faster within 20-30 days. But in some lower intensity regimens, that takes just longer time.
Dr. Ravandi, we're talking about deep remissions, molecular remissions. There are several techniques, as we all know, in leukemia to measure small amounts of leukemic cells. And we have in Philadelphia positive ALL, we could do it by flow cytometry, looking for clones of immunotherapy defined clones of leukemic cells. We could do, I suppose, next generation sequencing, but more commonly we would consider PCR for BCR-ABL, just like we do in CML. Which technique do you think is most appropriate in Philadelphia positive ALL to assess the depth of remission?
I think currently using PCR to look for BCR-ABL transcripts is probably the gold standard. We did an early study several years ago where we used flow cytometry, and we also actually used immunoglobulin chain rearrangements, but not you just using a consensus primer, not a patient-specific or clonoSEQ-based assay. And that wasn't very effective, as you would imagine, because it was not a patient-specific assay. With flow also, there was some definite difference between patients who did achieve flow negativity as compared to those who remained flow positive. But in that study, and again, this was a very old test, BCR-ABL clearance was clearly a better indicator of improved outcome for patients who did achieve major molecular response, and then particularly those who achieved a complete molecular response. More recently, Dr. Nick Short in our group compiled our experience on patients who didn't go to transplant and were assessed for a molecular response. And he did clearly show that achieving complete molecular remission about 3 months after achieving response was clearly associated with improvement of survival and improvement in relapse-free survival. So I think that has become a sort of a gold standard. And this has also been shown by other groups. The Korean group did show on a study that they achieving a molecular response even before transplant was associated with better outcomes. And this has been really replicated multiple times across all countries, that achieving a molecular response using BCR-ABL transcripts is a good predictor of outcome.
So I think I totally agree with the good prediction, the good prediction of outcome if you are molecularly negative. The big question is, what about if you're molecularly positive? Is there anything we can do about that? If we can convert you from molecularly positive to negative with antibodies or something, is that going to change the outcome? That's something we really don't know. So there's a lot we do know now in Philadelphia positive ALL. But to start to wrap up here, we know that you need to use a tyrosine kinase inhibitor. We don't know which one to use, although ponatinib is the most potent, as you pointed out. It does have some more risks. There was a trial sponsored by a drug company of ponatinib versus imatinib and minimal chemo that's going on now that may confirm that it's safe and a good idea to use ponatinib. Dasatinib has the most data, not that much from bosutinib and nilotinib. Deep remissions, however measured, usually by PCR for BCR-ABL, is really the goal, and that will lead into other discussions about how to go from a deep remission to cure, specifically whether or not you need transplant. But we can all agree that a durable response in the beginning is very important. So thanks again for joining us for this segment on the best tyrosine kinase inhibitor for frontline treatment of Philadelphia positive AL. Please be sure to click on the landing page for this activity to claim your CME credit and to assess other topic segments, such as the role for chemotherapy in frontline treatment of Philadelphia positive ALL, the role of allogeneic stem cell transplant in Philadelphia positive ALL, as well as patient case scenarios. Thank you very much for listening.